Well, we are going to start with a very difficult topic, I would say, in general surgery. We usually teach those things as tropical diseases. Well, these kind of diseases will come into MCQs, and it will be, and sometimes you sit in the exam and say that we haven't studied that. So we're going to start with that, and I'm going to go one by one. And the first thing, in surgery, physiology is the king, anatomy the queen. You can be the prince, but only provided you have the judgment. What are the learning objectives of this lecture? To be aware of common surgical problems in tropics. To appreciate patients do not seek medical help until late in the disease. Emergency presentations of various common conditions we are dealing with. Now, what are the common conditions? These are one of the common conditions that we are going to discuss today regarding the tropical diseases. So, what are the tropical diseases are, where they are located? There could be protozoa, there could be bacteria, there could be virus, there could be helminths. Well, this is the area I have shown where you can see the neglected tropical diseases. Now, the first thing and the first disease which is very much common in our medicine and surgery is typhoid. Typhoid has got a very big role in surgery because a lot of diseases, gut perforations we get in typhoid. So the first thing is, what is the causative organism? The causative organism of typhoid is Salmonella typhi. How it gains entry? It gains entry into human GIT via poor hygiene and sanitation. It's normally managed by medicine. Surgeon's only role is emergency perforation in typhoid ulcer. And now, what's the pathology? And how this typhoid occurs? It occurs due to ingestion of contaminated food and water, colonization of bile patches, hypertrophy of lymphoid follicles followed by necrosis and ulceration. Bowel may perforate at several times. How would you diagnose a case of typhoid or typhoid perforation? The patient presents in or recently visited endemic areas. Usually, patient presents with persistent high temperature and is toxic. Now, what they say that in the past they used to say that it's a Bowel test, you're going to do it, the positive or any other test. But now then came the typhoid dot. But the best thing is to get a positive blood and stool culture when the patient is already on treatment. Now, in typhoid, after the second week, signs of peritonitis, they might indicate the perforation confirmed. We always say free gas under the diaphragm. That's one of the surgical emergencies we get in a surgical ward, usually in the summertime, is that patient is running a high grade of fever and is toxic. And when you come in and do the abdominal series X-rays, in X-ray chest, you get gas and diaphragm. What has happened is that the part of the ileum has perforated due to typhoid. Now, what's the treatment of bowel perforation? When it gets perforated, when we get a patient with peritonitis, what we do? We do resuscitation, intensive care. Common site of perforation is terminal ileum, which can be multiple. Laparotomy is type of various procedure. Now, laparotomy is a key to do it. In a very sick patient, consider extravasation. Now, what is extravasation? Extravasation is that when the disease is so much and one can't close the perforation and there are chances of contamination and leakage, we take the bowel out and part of bowel out and we extravase them and do the ileostomy. That is the safest procedure you have ever got. And we always close the peritoneum and leave the wound open for secondary closure. Now, we do close the sheath, but we don't close the skin because it is important that you leave it because the wound persistently tends to get infected in that case. That's why. Now, the second disease, which is very common, is ASCARIS. lumbricoides. ASCARIS lumbricoides, commonly known as a roundworm infestation, affects more than a quarter of the population. Commonly, it's intestinal pneumonia. It's fecal transmission, and it's more common in children rather than adults. Now, what is the pathology and clinical feature? They've got fertilized eggs present in soil, reach intestine with contaminated food, release a larva, travel to liver via portal circulation, then through systemic circulation to lungs. Larval state in lungs causes dry cough, chest pain, dyspnea, and fever known as Loeffler's syndrome. It can lead to small bowel obstruction by bolus of adult worms in terminal ileum, leading to pressure necrosis and perforation. Worms can migrate to common bile duct, causes ascending cholangitis and jaundice. Now, this is the what you call the theme chart or the scheme of it. How the ASCARIS is caught. It's transmitted through soil-infested with human feces that contain ASCARIS. Then symptoms, you can see that it's going to be present with swelling of abdomen. It can present severe abdominal pain, malnutrition, anemia, impaired physical growth. What is the treatment? We give albendazole, mebendazole, and surgery is only the possibility, is also a possibility, and worms have caused extreme damage when there's a perforation infested in the gut when it doesn't respond to the medical treatment. Now, what are the investigations that we are going to do in case of ASCARIS lumbricoides? The first thing is increase in allergic eosinophilic count. But when we do the stool examination, it may show ova and cyst. Sputum and bronchoscopic washing may show charcoal Leiden crystal or lava. Chest X-ray may show fluffy exudates. Ultrasound may show worms in common bile duct or pancreatic duct. Barium meal follow-through may show scattered worms. Now, what's the treatment? The conservative line of management with anti-helminthetics is the first line of treatment. Surgery is the last resort. If the obstruction is not solved by conservative means, perforation following obstruction. Now, the third disease, which is more common, is amoebiasis. Amoebiasis is caused by Amoeba histolytica, but half of the population in tropical countries infected. The mode of transmission is fecal-oral. Amoebic liver abscess is most common. Extraintestinal manifestation occurs in less than 10% of infected population. How it's going to present? The clinical presentation, it can be asymptomatic. Now, patient can present you with no symptoms. They could be asymptomatic. They could be symptomatic infection. They could be intestinal disease, and there could be extra-intestinal manifestation. Now, this is the scheme. It shows you it's non-invasive. The colonization happens. Asymptomatic cyst passer. Patient can be asymptomatic cyst passer. A patient might complain that I am passing cyst in my stool. It could be non-dysenteric diarrhea. Patient may present with abdominal cramps and other GI symptoms. Now, how this invasive thing occurs? It's a necrosis of mucosa, ulcers, dysentery. Now, this ulcer enlargement leads to dysentery and peritonitis. And metastasis happens, giving to extraintestinal amoebiasis. Now, there could be hepatic abscess, there can be empyema formation, it could be rupture into pericardium, there can be cerebral abscess, there can be cutaneous amoebiasis. Now, this is the gross pathology of intestinal amoebiasis showing extensive ulceration. This is another picture of it. You can see that there are ulcers down there. This is the ulcers with the raised border with a little inflammation between the lesions. Now, these are the typical flask-shaped ulcers we get in amoebiasis. They're in the mucosa and small opening on the mucosal surface. Now, this is typical amoeboic colitis, in which you see severe dysentery with multiple ulcers in the large bowel and the bloody diarrhea. What is amoebioma? It's a chronic granuloma in the large bowel, most commonly seen in Sikandar. It is seen in patients with long-standing chronic infection not properly treated with drugs. It can be mistaken for carcinoma. Now, what's amoebic liver abscess? This is the most common extraintestinal manifestation. Adults are affected more than children. Males are affected more than female, and 20% have history of dysentery. What is pathogenesis? Journey of enterohistolytica to the liver. Direct extension can occur from gut to liver. Can be due to via portal circulation. Can be via lymphatics. And it could be infection due to enzymatic dissolution. Now, this is the shaggy appearance in the walls of the abscess. Well, shaggy is a word usually most oftenly spoken in America. When anything dramatic happens, an out of way happens, that's it, it's a shaggy appearance. So that's why I've used the word here. Now, this is an abscess surrounded by distinct area of severe congestion. You can say that there are patches of severe congestion in them. Now, this is an abscess showing a thick fibrous wall. You can show that a thick fibrous wall has been made in the abscess. Now, what are the clinical features? Now, clinical features can present with many symptoms like pain, diarrhea, dysentery, weight loss, cough, dyspnea. What the physical signs we're going to look for is localized tenderness, enlarged liver, fever, rales, rhonchi in the chest, localized intercostal tenderness in the chest, epigastric tenderness, and it might often present with jaundice. Now, this is the surface of the left lobe where it is presenting with. Complications. There could be a rupture into the pleura, peritoneum, pericardium. There could be amoebic brain abscess. This could be hemophilia, portal hypertension. What's the treatment? Medical treatment is effective, should be the first line of choice. In large abscesses, repeated aspiration with drug treatment. Surgical treatment reserved for complication only such as ruptures. Acute toxic megacolon and severe hemorrhage treated with intensive therapy followed by resection and externalization of the bowel. Now, this is very important disease, which is very much important in tropics, and it's a main kind of tropical disease we get is Lymphatic. Well, it's a kind of a way in which we get a swollen leg. There's a major lymphadenopathy. Sometimes it's difficult to treat, and there are usually MCQs in the exam regarding this disease, and this disease is very much asked in the exam too in the Western world. Now, what is elephantiasis? Elephantiasis is caused by a parasitic flare worms that feed off the humans through the lymphatic system. These worms, listen to me, this is very much important. These worms live for 6 to 8 years and produce millions of microflora during their lifetime that circulate in the blood. It can also be transmitted by different type of mosquitoes. Now, what are the symptoms that because not presented? The worms causes swelling in the limbs and genitals. These deformities can lead to social stigmas now and financial hardship and social economy because they'll be swelling in the leg. Person will be unable to walk. He will have a tracking pain, and that's I have used the term social stigmas. Now, what's the treatment? The recommended single dose of two medicines together, that is albendazole with ivermectin or diethylcarbamazine. Mosquito control through insecticide-treated nets or indoor spray. Well, there are 807 million cases worldwide. That shows that. What is hookworm? Hookworm is caused by an intestinal parasite. What are the hookworm symptoms? They are abdominal discomfort, diarrhea, anemia, severe weight loss, loss of appetite, fatigue, and weakness. What's the treatment? Treatment is medication through albendazole, levamisole, and parenteral. A hookworm vaccine is in the development. Now, what is hookworm aglomatosis? Hookworm disease is one of the most important parasitic disease of humans. Number of humans infected is estimated at 1.2 billion, with 50,000 to 60,000 deaths each year. Causative agents, obviously, there could be 4 species can attack human. Is Encyclostoma duodenale, Old World hookworm, Nectar americanus, New World hookworm, and Ankylostoma brasiliensis, cause creeping eruptions is most commonly shows in Brazil, and Anelostoma cranium causing creeping eruptions. For the clinical features of hookworm disease, they are usually different at different sites. On skin, like dermal, there could be local erythema, macules, papules, what you call as groundage, cutaneous invasion and subcutaneous migration of larvae through lung, bronchi, and trachea. Gastrointestinal can be present with anorexia, gastric pain, GIT hemorrhage, attachment of attal worms, and injury to upper intestinal mucosa. Now, hematological, it can cause iron deficiency anemia, hypoproteinemia, edema, and cortic loss. It could be intestinal blood loss, which also impacted. Now comes the major killer in the, what you call it, the third world, the eastern part, what we call used to, well, that's remedy of my consultant used to say that this is a disease of the third world of Pakistan and India, which is very much common. And we come across tuberculosis a lot. And this is a disease got to be known if you're practicing medicine back in this country in India. Now, what is tuberculosis? What's the tuberculosis importance in terms of general surgery or surgery? There are some basic facts about the tuberculosis. Tuberculosis is a chronic necrotizing disease caused by Mycobacterium tuberculosis complex. Usually affects the lungs, but almost all organs can be affected. This is conveniently classified into pulmonary tuberculosis, accounts for 80% of all tuberculosis cases. Now, how would you do? We could be smear positive. Could be 75 to 80% of all pulmonary tuberculosis cases. Smear negative can be 20 to 25% of all pulmonary tuberculosis cases. What's extrapulmonary infestation? Accounts 20% of all tuberculosis cases. Now, we could divide it like, first there is a latent infection, then there is a cavity happens, we call it cavity tuberculosis. And we call, and then there's a miliary appearance. We usually call it, yeah, you would have seen in medicine, there's a miliary appearances, and we call it a miliary tuberculosis. Now, what is the pathogenesis of tuberculosis? Infection begins when the inhaled droplets reach the alveoli of lungs. Tuberculous bacilli multiply. A number of tubercle bacilli enter the bloodstream and spread throughout the body, through lungs, kidney, brain, bone. Within 2 to 10 weeks, the immune system produces an immune response which encapsulates the bacteria and is detectable with GST or agar blood test. Well, this is the most common question asked, and whether you are in final year, your 4th year, you become a doctor. These are the drugs which should be known by every doctor if you're practicing medicine in Pakistan. That's the first line of drugs you're talking about. Let's get to it. Excuse me, beta. Just hold on for me.
ना ज्वाइन थी और ये लीव करे वापस जो करना नहीं है पे मोकलाएंगे तो जल्दी ज्वाइन
Yes, we were on pathogenesis of tuberculosis. How it happens. Now, infection begins when the inhaled droplets reach the alveoli of the lungs. The tuberculous bacilli multiply. A number of tuberculous bacilli enter the bloodstream and spread throughout the bodies through lungs, kidneys, brain, and bone. Within 2 to 10 weeks, the immune system produces an immune response which encapsulates the bacteria and is detectable with TST or agar blood test. Now, what the first line of drugs? These drugs should be learned by heart, and every doctor should know if you're practicing medicine in Indo-Pak, India, or Pakistan. The first line of drugs is isoniazid, INH, or rifampicin, bezalamide, ethambutol, rabinafil, and rapamycin. Now, what is the second line of drugs? It's streptomycin, cycloserine, aminocyclic acid, economanide, amikacin, sapromycin, levofloxacin, moxifloxacin, and gatifloxacin. Now, what is filariasis? Now, this is very much important. How the filariasis parasites happens. What is filariasis? Filariasis is caused by an organism usually known as Wucheria bancrofti. It is kind of in which lymphedema happens, and we got a lot of patients like that in the Western world who live in the tropics and in jungles. It's a widely spread disease caused by parasites. Now, what are the organisms which cause this? One is Monacella ozati loa, Dipeta lonima, persistens, Diastroprea oncaria volvulus, Bugia malaya, because this is most common in Malaysia and Timori. The main organism which you're going to get is Wucheria bancrofti. This inhabited of lymphatic subcutaneous tissue, peritoneum, or thoracic cavity. Now, this is the main picture where you get a patient of filariasis. You can see the leg, it's much swollen. Now, how the lymphatic filariasis happen? Lymphatic filariasis is a parasitic infection spread by mosquitoes that is endemic in 83 countries. with over 1.3 billion people at risk of contracting it. Worms reside in the lymphatic system where they live 4 to 6 years, producing millions of microfilariae. They circulate in the blood and picked up by mosquitoes. What happens as a result? There is a swelling of limbs and breast, lymphedema. It can be genitals leading to hydrocele. It can be swollen limbs with dramatically thickened, hard, rough, and fissured skin. Now, how the lymphedema is managed. Treatment of uncomplicated acute dermal lymphadenitis. Give analgesic paracetamol 3 to 4 times a day. Give oral antibiotic like penicillin in 1.5 gram in 3 doses for 8 days. In case of allergy to penicillin, give oral erythromycin 1 gram 3 times a day. Clean a limb with antiseptic. Check for any wounds, cuts, abscesses. Give antibiotic cream, and interdigital infection. Give antifungal cream. Now. The disease which is used to be called untreatable, and like in the olden days, like leprosy were called as Hansen's disease. What is that? It's a chronic contagious disease primarily affecting the peripheral nerves, secondarily involving skin, mucosa of the mouth, upper respiratory tract, reticuloendothelial system, eyes, bones, and testes. As a classification, there are 4 classifications. One is lepromatous leprosy, tuberculoid leprosy, borderline leprosy, and intermediate leprosy. For the pathophysiology, the areas most commonly affected by leprosy are the superficial peripheral nerves, skin, mucous membranes of the upper respiratory tract, anterior chamber of the eyes, testes. These areas tend to be cooler parts of the body. Tissue damage is caused by degree to which cell-mediated immunity is expressed, the extent of bacillary spread and multiplication, the immunologic complications of the lepra reactions, and the nerve damage and its sequelae. Now, this is the leprosy in the older woman. You can see that. What is multi-drug therapy for leprosy? Multi-drug therapy is used to treat DASFON-resistant strains of myopathic leprae and shorten the duration of treatment. Now, what are the drugs? Rifamycin, desposone, and clofazimine. Multi-bacillary, you give 600 milligram once a month, 100 milligram daily self-administered, and 300 milligram once a month. These are different kinds of regimes you can easily copy from Google. Now comes the poliomyelitis, very much common, not been eradicated till yet from our country. Poliomyelitis, often called polio or infantile paralysis, an acute virus infection disease, is spread from person to person, primarily via the oral-fecal route. The term poliomyelitis derives from an ancient Greek word. Polio means gray and myelus meaning marrow, reflecting the gray matter of the spinal cord. The suffix X denotes inflammation, i.e. inflammation of the spinal cord's gray matter. A severe infection can extend into the brainstem, even higher center, resulting in polio, encephalitis, and apnea. What's the pathogenesis? Incubation period is usually 7 to 10 days. We can say it can be from 4 to 35 days. It can be fecal-oral, it can be inhalation. When it is, it can infect the pharynx and intestinal mucosa. gains entry by ending into immunoglobulin-like receptor known as the poliovirus receptor, a CD5 on the cell membrane. Now, the ports of entry gets it through mouth, gets through local multiplication, and there could be a minor primary viremia. What gets multiple in the neurons, leading to lesions, are most commonly in anti-horn cells of the spinal cord, causing flaccid paralysis. Or can travel to spinal cord and brain, destroys them. What are the features of clinical forms of poliomyelitis? Ali, device unplugged here. Device unplugged here. Then to the
3D device.
Message.
Some videos on your participant को बड़ी तरह कम करे हो बेटा आप लोगों को
बेटा can you listen me? Hello? Yeah, are you following the presentation? What are the clinical forms of poliomyelitis? It can be paralytic poliomyelitis, like spinal, bulbar, pontine, encephalitic. Can be aparalytic poliomyelitis, like visceral, abortive, or meningeal. What's the treatment? The goal of the treatment is to control symptoms while infection runs its course, as there are no specific treatment for this viral infection. People with severe cases may need life-saving measures, especially breathing help. Symptoms are based on their severity. Treatment may include, there could be antibiotics for urinary tract infection. People with severe cases may need life-saving measures, especially breathing help. Symptoms are treated based on their severity. Treatment may include antibiotics for urinary tract infection, moisture to reduce pain and spasms, painkillers to reduce headache, muscle pain and spasms. Physical therapy or orthopedic surgery may also be provided to help in recovering muscle strength and function. Now, what we call it Asiatic cholangiohepatitis. Well, the kind of infection we get is that the most common infection of bile duct that usually shows the ascending cholangitis in which the organism develops. So, what is Asiatic cholangiohepatitis? It's Oriental cholangiohepatitis. Chronic risk sensitives for liver fluke, hepatobiliary system. It get effects in Southeast Asia. Seaports, river, estuaries, those who commonly live around the water. They reside in snails and fish, but intermediate host. Pathology is ingestion of contaminated food and water. There could be colonization of bile patches, hypertrophy of lymphoid follicles followed by necrosis and ulceration. Bowel may perforate at several sites. What is Asiatic cholangiohepatitis? Is endemic in, now this is the feature of Asiatic cholangiohepatitis. Endemic in Far East, Fluke 25 meter long, 5 meter wide, with inhibited bile ducts, can cause thickening of bile ducts, may be asymptomatic. Symptomatic cholangitis, biliary pancreatitis, colic stones, cholangitis, cirrhosis, bile duct carcinoma. Treatment, polytocotomy with T-tube insertion, polytoco-titanostomy. Liver fluke, facial species found in the liver, biliary passages of human and ruminant. Facial hepatitis, heat, liver fluid, temporary liver fluid, common liver fluid. Facial giginitis, giant liver fluid, and tropical liver fluid. What is investigation? We usually get eosinophilia, stool examination presents with BOA, can be sputum or bronchoscopic washing, charcoal Leiden crystals or lava, pulpy exudates in Loeffler syndrome, barium leaf and follow through, bolus of worms in ileum, or lying freely within the small bowel. Ultrasounds, they could be worms, it's common bile duct, and pancreatic duct. MRC, magnetic rectograph, pancreatocolonography, knocks abdomen, and worms in CBD. This happens. What is in the liver cycle happens. Eggs passed out with feces, eggs ingested by snail, the first intermediate host inside the snail, the egg goes undergo microdia cilia for swimming, asexual wrapper, worms-like stage, as tail in swimming, free swimming crackway burrow out of skin snail and search out of fish and plant, the second intermediate host. Cercaria insist in fish, plants, and called mastocyria, which is then ingested by human or other vertebrate. Mycobacteria exist in intestine and migrate to liver where they live, feed. Well, this is a cycle you can easily download from the Google, but if you can see that this is the whole cycle through which liver fluke life cycle happens. What are symptoms? It's more common in the sheep. 10,000 per microfilia consumed at one time. Dramatic liver inflammation. Frequently resulting more common and rarely fatal. Non-specific. Eating. Raw infected liver, infected pharynx causes swelling and obstructive breathing. How do you diagnose? There can be stool samples for yellow-brown eggs. Eggs don't show for 4 months. Georgiana biliary aspirate. Antibody test. Can detect 2 weeks after infection. Ultrasound visualizes adults in bile duct. CT scale reveals burrows in the liver. What's the treatment? Biotinol, highly effective, large dose, high cost, long treatment period. Triacalbendazole, easier to use. 1 to 2 oral doses in 24 hours. Virtual 100% effective. Last resort is, obviously, we all love is surgery. Now we stop and we are finished with our lecture. And the next time I'm going to continue on next Wednesday with the trauma. If you have any questions, please ask. Well, this lecture will be delivered to you, recorded, and will be delivered to you on your WhatsApp group. YouTube channel pe beta chala jayega if anybody wants to listen it. Now, you have any questions? Please ask me. Beta. जी बेटा yes बेटा